Are you seeing it being taught in residency? Because again, if we're teaching our residents, our trainees primarily to get comfortable that way, then it becomes a shift in how we practice as opposed to just a few select surgeons around the country.
You make a very good point. I think the key to a safe implementation is standardization and good teaching. And I think that's what we've been trying to focus on most, is to really get the technique standardized, because the more standardized it is, the less room of variation there is in people in their learning curve, and the lower the learning curve is going to be. And then it's proper training. And I think that's where you mentioned them. Applied Medical's helped us a lot with those standardized training courses. We now give exactly the same training courses all over Europe, all over the US, in many other countries, and in Australia, and it's all a standardized content. It's exactly the same presentations. It's exactly the same steps. And I think that will really help in keeping our complication rates down. It is something that worries me, because most techniques go through that Gartner cycle, where it takes a long time in the beginning to get the adoption going. And then, all of a sudden there's a lot of excitement about the technique, and a lot of people get started, and not everyone necessarily goes through the right training steps. And you get a peak, a lot of cases get done, but then you get to a level where you start seeing the complications coming. And then there's going to be a bit of discredit to the technique, because there's going to be reports on complications. And at that point, we're going to need the evidence to prove that in the hands of people who've been properly trained in a standardized way, this is what our complication rates are, and they are not higher than they are in standard other techniques. And I think that's where the studies are important, and where the big complication or case registry, the International Note Society has a big case registry that's been going since 2015, where a lot of surgeons put their data in, and there we'll be able to see now what actually the complication rates are in the hands of experienced surgeons. And hopefully, when that dip comes and the complications start coming in people who haven't gone through the proper training, that's what will help us defend the technique. Because what we see in the studies is that the complication rates are not higher than in other techniques, if not even a bit lower. So I think that's the job for science now, to get the technique established.
What are specific complications? What are complications that are unique to vNOTES? Because as I think about going through and doing a hysterectomy laparoscopically, I have the same steps. Every case is the same. Again, doesn't matter on the uterus. It's just like always the same steps, just different amounts of time spent on each one. But with my uterines, taking them more medially, so if it retracts, I've got a nice pedicle. Like, how do you chase a pedicle laterally outside of the ring and those kinds of things? What are specific challenges and complications that one can expect when starting to introduce vNOTES into your practice?
I think what you say on the uterine artery is really important there, because obviously bleeding is our most common complication in all procedures we do, all techniques. I think specifically to vNOTES, you get, we're talking hysterectomy now, if you take the uterine artery, you get it right at the start of the case, not at the end of the case, and without going retroperitoneal. So that's a benefit. But a downside is that if you don't seal it properly and you cut it, it will retract behind the Alexis ring, and then it becomes more challenging to catch it. Now, if that happens, we take the ring out, you pull on your pedicle, on your uterosacral pedicle, and then you can grab it vaginally. But that's a moment where you need some vaginal experience to grab that. I think the main thing we always stress in teaching is that just take your time for that uterine artery, and don't just take it once with a sealing device and be confident with it. It will work 9 out of 10 or 98 out of 100. But there will be a couple of cases on a larger uterus where you're putting more traction, where that is not enough of a seal. So, take it a couple of times next to each other with your sealing device or with a standard bipolar before you cut it. Take your time on that uterine artery, and then it's never an issue. And also, once you've done that, the rest of your hemostasis is easier. Then you can speed up and don't need to worry so much.